Ultrasound doesn't give you an exact pinpoint degree of how bad a blockage is per se, and what I mean by that is we get a range from it. It gives us a general feeling of how bad it is, and we basically divide severity of the disease in carotid artery stenosis basically on mild, moderate, severe / critical. And basically, anything that we see that's less than 50%, which a large majority of our patients demonstrate, we consider mild. Now, mild only is describing the amount of blockage that's there. Just because it may be described as mild doesn't mean that you're not at a risk of having stroke, because as I talked about earlier, this blockage that potentially can fracture and release the material into the blood, clots can form on that, and you can have just as a severe stroke as if you've had, a 90% blockage in your carotid artery. From there, we basically grade 50 to 70% as moderate disease, and anything that's greater than 70% we consider severe. When we start getting into what other types of tests that we run to evaluate patients' blockage in the neck arteries, depends on a few things. I think first and foremost, depending on whether they have symptoms or not. And what I mean by symptoms is what Dr. Vereen alluded to earlier. If you have weakness on one side of the body that suddenly occurs, numbness, slurred speech, difficulty getting words out, abrupt visual changes, loss of vision. All these are signs of neurological events that could be related to a stroke. When a person describes symptoms like these, we certainly get a little bit more aggressive in looking at the blockage outside of just ultrasound. First and foremost, CT angiography or CAT scan, where we use a dye and a special technique, gives us excellent views of the carotid arteries and all the arteries related to that system. It's a very accurate modality, and for a larger extent has replaced conventional angiography or invasive angiograms, where we actually go in through the leg and take pictures in the cath lab. Other modalities that we could use are magnetic resonance imaging, or MRI, but it's called MRA when we use dye with that. When patients have severe disease noted on ultrasound, we generally will do one of these dye tests, whether they're symptomatic or asymptomatic. If it's moderate with symptoms, we will generally do CT angiogram or conventional angiography to evaluate this.
That's a very thorough summation of the different categories or levels of severity of carotid disease. And of course, as he alluded to, again, I'm reiterating it, is that irrespective of the severity of the blockage, also when we look at it, we are concerned about the complexity of that blockage, which is a little more technical. When you talk about complexity, you're looking about the irregularity and ulceration and possible bleeding into that, which those finer points can be discerned when you go on and do CT scans, or a thorough ultrasound study can sometimes raise our concern. Or of course, if the patient has a symptom that you cannot otherwise explain as to why they had a stroke or stroke-like features, even if a blockage is 50%, it is not uncommon for us to go and treat a carotid artery by some form of interventional technique. We'll talk about some of the interventional techniques as well. And I also want to remind our audience it's a live call-in show, and they're welcome to call us anytime during this show about any questions regarding cardiovascular disease as well as carotid disease pertaining to this show. And coming back to our carotid disease, now when we talk about 40 to 50% blockages, like the majority of the blockages that we encounter in our practice, bulk of the treatment is again risk factor modification, as all of us do day in and day out, which involves first and foremost again treating of high blood pressure with an appropriate combination of medicines. Treating of, if they're cigarette smokers, we encourage them, of course, all the time, really goad them or nag them more like, and by any means to stop smoking, because as I said earlier, it is one of the biggest risk factors for carotid disease as well as the risk of stroke. So nowadays there are other modalities, even some forms of medical therapy that we can use to help them reduce their craving and get off the smoking. And then the cholesterol that we always treat with dietary modification, as well as medical therapy, including the statin therapy with various combinations, which will reduce, thereby reducing the cholesterol is not just reducing a number, you're stabilizing the core of the so-called plaque, making it less vulnerable, more stable, so it is less likely to rupture. The risk, as he explained earlier on, when you take a little plaque or a buildup, it is more like a volcano, and when that volcano ruptures or a blister ruptures, although it may not be a severe blockage, if the particles end up migrating to the brain, you end up with a stroke. So I think majority of the treatment of mild to moderate carotid disease, which is 40 to 50%, entails medical therapy, and also starting off blood thinners such as aspirin, and in some instances going on to Plavix, which is a much stronger antiplatelet or anti-clotting cell treatment that we use. And we go on indefinitely, and we keep following the carotids with the simplest modality, namely the ultrasound. Based on the severity, we tend to follow them, let's say, every year typically, and sometimes if we are more concerned about a certain patient, we can go up to even 6 months in duration. And now going on to the next level of this discussion, now that we have discovered carotid disease and we quantified it as a certain degree of severity, and Dr. Hammond, if you can shed some light on the historic methods of treatment of carotid disease in terms of intervention. There are really two main methods, but I guess historically carotid endarterectomy has been considered a very good surgery and was done for at least 40 years or more that we know of, and has been considered a very good surgery. So please shed some light on that procedure to the audience.
Well, what Dr. Farina is alluding to is the carotid artery endarterectomy is the technical term, and the layman's term is just carotid surgery or scraping of the carotid. And literally, it's a very straightforward procedure where the surgeon, under general anesthesia, actually opens the neck, the skin on the neck and the muscle, and then cuts down to the artery and gains control of the blood, and actually opens the artery and scrapes it out and cleans the inside of the artery out, getting the plaque that we've been talking about all night, and actually cleaning the artery out and scraping the plaque out of the vessel. That is a time-proven method that's been around for years, as Dr. Farina was saying. And the recovery time for that generally in recent time is 2 to 3 days in the hospital, maybe a day or two longer, maybe a day shorter, depending on other circumstances. But generally a fairly short hospital stay and a pretty quick recovery time. And it's a tried and true method. It's fairly low risk, but there are patients who, for one reason or another, are not amenable to that procedure, or maybe at a much higher risk than the average patient. Those people who say have bad lung disease and can't be put to sleep safely, or maybe a patient that the artery blockage is way up more behind the ear instead of down in the neck. Their artery is just longer and reaches further up, and the surgeon can't actively reach that. So there are certain circumstances that make the plain surgery more difficult, or at least significantly more risky than we would like to do. And now we have a newer technique of the carotid stenting.
Well, that's very true, and carotid surgery has been in existence for a long time, as we just talked about. And now that you really highlighted the pros or the benefits of carotid surgery, all of us know that carotid surgery, by cleaning up and basically sometimes even expanding the artery bulb by so-called angioplasty, where they put a little graft material and even make it more bulbous. It's time tested, and I want to ask Dr. Mignot as to what would be the downsides of going through such a surgery, and what are the real benefits. Of course, we know benefits of reduction of the risk of stroke and reduction of that plaque. What are the downsides, if any, of carotid surgery, and why the need for evolution into different other procedures for carotid disease?
Well, obviously the reason to have surgery is to prevent stroke, and that's the main benefit that one gains from that. However, the surgery itself, you have a risk of having a stroke. As Dr. Hammond was describing, as the artery is cleaned out, there are instances where these particles, the surgeon can't always prevent them from going up during the procedure. and a patient potentially can have a stroke as a result of the surgery. Recovery time, as we talked about, generally 2-3 days or so. But you also have to remember it is a surgery. It's an invasive procedure where tissue is cut. There are risks of infection and so on. But as Dr. Verena was describing, there are instances where you would want not to have possibly such an invasive procedure. Currently, we do now carotid stenting, just like we put stents in heart arteries to open them up. The same is done with the larger vessel in the neck. The big advantage to that is basically overnight stay. The risks of stroke with putting a stent in the carotid artery is still up in the air as far as what the current research data shows, but it's just as safe and in some instances not, safer than having open surgery. The recovery time is a lot quicker. It's less invasive, much less risk of having infection and complication just related to the surgical procedure itself. And just, in commonsensical thoughts is that would you rather have your neck filleted open or have the blockage fixed through a small pinhole in your leg? That's basically how a lot of patients look at it and prefer that method.
I guess that is what has led to the evolution of certainly all the cardiac procedures as well. Historically, they've done bypass surgery. In the beginning, when we detected blockages in the heart arteries, bypass surgery was initially considered the only method but as the need to do something less invasive comes up, and the patients typically drive these procedures, and that all of us want more and more sophisticated and simplify our lives so we're not put down, we don't stay in the hospital for prolonged periods, we are not down with the morbidity of the procedure itself takes several days. And then heart surgery is probably a lot bigger than a carotid surgery, but it's predominantly the need and the drive of the patients for wanting simpler procedures that are equally or more effective that led to the development of carotid stenting. And talking about surgery, of course, with surgery, besides the risk of infection, besides the risk of bleeding, there is also the risk of nerve palsies or paralysis of the tiny nerves that supply the vocal cords, and these which can sometimes lead to permanent hoarseness, but most times it is typically temporary hoarseness or difficulty in swallowing, which resolve with time. But these also have to be considered, and of course the risk of stroke, which typically in the hands of a good surgeon is probably less than 3%, and if it's a low risk type of procedure in a good institution, it is typically closer to 1%. So after we take this call from Mary from Eunice, we'll go back and we'll take a little break and then go back into discussion about carotid stenting.
Hello, Mary.
Hi, I was calling to find out, is everyone a candidate for carotid stenting?
Mary wants to know if everyone is a candidate for carotid stenting. Kyle, I'll let you answer that since you make that decision every day.
It would seem simple to think that since if it is such a safe procedure and such an easy procedure, why not everybody walks in that has a carotid blockage go for carotid stenting instead of carotid surgery? But the fact is that carotid surgery, as we talked just a little while ago, has been in existence for close to 40 years, and there is tremendous amount of data related to carotid surgery. Anything else that will be done, which is primarily stenting, will invariably be compared to carotid surgery. And since historically surgeons have been the ones doing carotid surgery, no other specialists were doing. But as it came to stenting, other specialists such as radiologists who really probably pioneered the whole field of carotid stenting, and then subsequently interventional cardiologists like some of us got into the field. So there is always some kind of professional rivalry, which is good and bad in that it is good in the sense that it keeps us on our toes to make sure that the procedure is done under appropriate circumstances and you're diligent in selecting the right patients and doing the right type of thing and following up the patient. And also in institution to institution, if you chose to do carotid stenting, first and foremost, of course, as you know, that it's a highly restricted procedure. You have to do it within the realm of certain trials of which are approved by the FDA, where we can enroll even asymptomatic patients under certain special circumstances namely if they are high risk for surgery. We'll go into more detail about who would be high risk for